Hi all, thank you for your patience. First, I wanted to apologize for the technical difficulties that we had earlier, but we are ready to start. Welcome to our conversation today about improving lung health. We will discuss early screening, diagnostics, and the latest treatment options for lung cancer. My name is Stephanie Heller, the Director of Holy Cross Health's Cancer and Women's Surgery programs. Our comprehensive lung cancer program offers patients screening options, ongoing monitoring, advanced diagnostics, innovative treatments, and all the support necessary along the way. We encourage you to participate, and with us today, we have two physician experts in treating many lung conditions. Dr. Brian Steinberg, a thoracic surgeon and medical director of thoracic surgery at Holy Cross Health, and Dr. Rennie Karras, a thoracic surgeon with Holy Cross Health Partners. Let's start with our questions. Dr. Karras, if you could kick us off by sharing who really is most at risk for lung cancer and for screening, should move forward with that.
So that's a great question. Good afternoon. We really look at a subset of population that is a previous smoker or current smoker over the age of 55, and other subsets such as Asian females. These subsets of the population tend to have a higher propensity for developing lung cancer, and appropriately so, as we will discuss, our screening guidelines go along screening for patients that fall into that category.
Thank you. And Dr. Steinberg, can you speak a little bit about screening guidelines and the criteria and why that's important?
Sure. The current guidelines are generally patients who are over 50 who have a 20-pack year smoking history or stopped within the last 15 years. And we recommend getting a low-dose non-contrast chest CT. And I think other patients who have strong family histories are potentially people who should consider screening, because we've learned a lot more about the genomics of lung cancer and familiar patterns. As Dr. Karras was saying, Asian females have a propensity who were never smokers but to develop lung cancers, Pacific Islanders. And I would also include people who had occupational exposures to asbestos or other chemicals may want to consider getting screened.
And what would you say your message would be to a smoker, a current smoker, or someone that had smoked in the past, and what their risk is for lung cancer and what they should do?
When I see someone in my office who smokes, I ask them to make a commitment to their health, to themselves, and that we will be there to help them. We actually have very good techniques that we can employ and very good adjuncts. So that with medications, we're able to take away the cravings, and we're there to help support people so they don't feel like a failure if they take a step back. And I think that's important, is for patients to be kind to themselves and give themselves a break too. I think one of the most important things is to make that commitment, because the dividends won't be seen today or tomorrow, but 5 years, 10 years, 20 years down the road, if we can get someone to stop smoking, it will have a huge impact, not just on the issues related to lung health, but across the board with respect to vascular disease, cardiovascular disease, cognitive issues. And I think that, it all starts with making the decision to seek help.
Thank you. That's very helpful. And Dr. Karras, if a patient does decide that they do want to move forward with a lung cancer screening, what should they expect? Can you describe the CT scan, any radiation?
Certainly. So we've made this very streamlined with our lung cancer screening protocols. So what they should expect is that they would come in and they would go through a CT scanner, which is much like an open donut. They would lay on a table, they wouldn't get an IV, and they would go through a CT scanner, and it would take maybe 60 to 90 seconds. This is a without contrast CAT scan, and it is, as Dr. Steinberg said, a low dose CT scan, which is actually 1/3 the radiation dose of a I would say, run-of-the-mill routine CT scan. It's important to consider because screening is very important for early stage diagnosis.
Thank you. And so they have their screening. What happens next? Let's say there's something wrong or if there's a nodule found. Can you explain what happens after that process, Dr. Steinberg?
Well, if something's discovered, we have to put it in context. Is the person a high-risk patient because of a smoking history or some other exposure or a family history? What is the size of a nodule that's discovered? And then in a multidisciplinary fashion, we discuss that with a group of radiologists, pulmonologists, pathologists, and decide what is the best course of action. Sometimes it's simply a matter of getting another CT scan in 3 to 6 months, or sometimes it may be that we have to do a biopsy, and we have a number of different means for doing that, whether it's sticking a needle into the nodule through the chest, or doing a endobronchial ultrasound, which goes through the mouth, or doing a navigational bronchoscopy where we can steer like GPS to a tumor and try to biopsy it that way.
And can you explain a little bit for the layperson what that means when you say biopsy, or to determine what?
Biopsy is to get a piece of tissue that we can look at under the microscope and make a determination as to what that is. Are these cancer cells? Are these unusual or what are called atypical cells that we have to watch or be worried about? Or is there some other explanation, some benign process? But we need to have some understanding of what's going on there.
And Dr. Kearse, what are both of yours? What is the thoracic surgeon's role with this detection?
So a thoracic surgeon's role is actually from soup to nuts. It's there from the beginning with, first of all, looking at the CT scan and figuring out in which direction you need to go as far as biopsy or continued screening with a serial CT scan 3, 6, 9 months down the line, or obtaining a diagnosis, as Dr. Steinberg has stated. And once we obtain that diagnosis, we can push forward and figure out which direction we need to go from that standpoint.
Thank you.
I consider us like the quarterbacks in helping guide the decision making in that process.
And how has the prognosis of lung cancer evolved over time, Dr. Steinberg?
Well, it used to be considered almost like getting a death sentence. Only about 15% of patients were eligible to get surgery. And the outcomes with surgery are really dependent on what the stages of the patient at the time of diagnosis. So the earlier the stage of discovery, the higher the likelihood for long-term survival. Since the advent of screening, we have flipped that equation, and now 85% of patients are able to get surgery. And we have very powerful techniques that are mostly minimally invasive, but take advantage of stereotactic radiation, as well as different forms of chemotherapy, immunotherapy, that the combination of all of this has radically transformed the outcome of patients. And so with screening and finding these tumors earlier, almost everyone now is eligible for some sort of definitive curative intent therapy that didn't exist before.
And is that because you're capturing patients at an earlier stage?
Absolutely. But not just that, we also now have the ability to treat patients that before were not necessarily surgical candidates, but we now have other very powerful adjuncts that we work in conjunction with our radiation oncology specialists and with our medical oncology specialists. So having this trio of people approaching the problem as a set of an either-or situation, we've been able to really transform the outcomes of our patients.
Dr. Kearse, can you speak a little bit more as to why this technology has evolved over time for the better, for capturing that earlier stage and the benefits of that?
So the benefits of capturing patients at an earlier stage, just as Dr. Steinberg was saying, is we have the opportunity to have patients not go through every aspect of treatment. Meaning, if you catch patients at an early enough stage, you might be able to just keep it to surgery. Meaning once surgery is done, you're looking at an early stage lung cancer and an 88+%, we talk about percent survivals, 88% plus 10-year survival. That's how much it's improved from even 20 years ago, 15 years ago till now.
Wow. Are there any specific symptoms that individuals should be on the lookout for, Dr. Steinberg, that may indicate they need a specialist, a thoracic surgeon, for a consult?
I think if there's any change in someone's normal state of well-being, if there's a sudden loss in weight, people are having coughs that don't get better, if they've developed a pneumonia that lingers, if they're getting worsening shortness of breath, if they're coughing up blood, those are clear indicators that there's something going on. But many patients are asymptomatic until it gets to be very advanced disease. And what we want to do is find people before they get symptomatic. So people shouldn't wait for symptoms and then be reassured by the fact that they feel fine. Just because you don't know that there's something there doesn't mean it's not.
And that's the purpose of the screening.
Exactly.
So you get the screening when you are asymptomatic.
Right.
That's very helpful. And then, Dr. Harris, other than treating lung cancer, what other issues do thoracic surgeons focus on?
So the thoracic surgeon's domain almost falls into everything from the neck to the upper abdomen. So thoracic surgeons will do everything from lung cancer to benign lung disease, which is identifying if there's a problem if you have lung disease via biopsies. They will do what we call masses in the chest, either at the front of the chest underneath the sternum or posteriorly next to the spine. They will deal with esophageal disease, both from reflux and hernias to esophageal cancers and upper gastric tumors.
Dr. Steinberg, anything else to add there?
Basically, everything from your chin to your belly button, we handle. And I feel that for thoracic surgeons, it's really a golden era because we have the ability now to do our procedures minimally invasively, either videoscopically or by using robotic surgery.
Can you speak a little bit about robotic surgery?
Sure. I mean, this has given us the ability to have the dexterity that we have with our hand, where we can move like this inside someone through an 8mm incision. And we have articulated instruments that the surgeon can control that provides the same degrees of freedom that their hand has. When you actually are working in a conventional operation, most of your arm movements are with your elbow and wrist. And you're able to open and close instruments, but you don't really have the dexterity that you have with your fingers. With robotic surgery, we actually now have fingertip dexterity inside someone through a tiny portal of entry, which is phenomenal. So I can take this big hand and actually put it inside someone without having to do it in actuality.
And when might a patient need robotic surgery?
Basically now we're doing almost all our procedures using robotic surgery. The issue really is, when can't we do it robotically? And very often we combine robotic surgery with more conventional surgery, again, reducing our incision size, making the surgeries less morbid, and making recoveries faster. And this actually has transformed a lot of the problems patients would have after conventional thoracic surgery, because they're not experiencing the disruption of the chest wall and having their rib cage injured and having chronic pain.
Excellent. And I know we do have a lung navigator at Holy Cross Health. Dr. Harris, can you speak a little bit about her role?
So she actually plays a wonderful role in our beginning to end to continued surveillance. A lung cancer navigator or lung center navigator really takes on many hats. First and foremost, getting in touch with patients to see if they have any needs that we might have not planned out for, which is very helpful when you talk about patients undergoing a diagnosis and a surgery that really puts a lot of stress on them and their families. She really gets to know our lung navigators, she gets to know these patients inside and out pretty much. She gets to follow along with them not only during their hospital course, but beyond when we follow national cancer guidelines and do our serial CT scan surveillance for up to 5 years with patients after lung surgery.
Excellent, thank you.
You know, when I see a patient in the office and we decide that they're going to proceed to surgery, I'll then give them maybe 6 or 7 requisitions of tests that need to be done. And it can be a challenging process to get that organized, scheduled, get the information flow, get that from my office to referring doctors, and having the navigator there as someone that the patient can reach out to help guide them is really invaluable. Then after surgeries, there are issues that come up for patients. Getting back to getting to see their oncologist, they're getting chemotherapy or not. And so there's this transition. And again, having the navigator, someone that the patient knows, that's accessible to them, that they can contact, is really a tremendous help. If there are clinical issues that come up, the navigator can then get the right person involved to help address those issues. Sometimes the patient has to go to the emergency room. Sometimes they need an expedited appointment in your office. They help,
Right.
you know, get that person through the system to where they need to be at that moment. The other thing is I have found for a lot of patients, just getting the news that you may have a cancer or that you need to get surgery becomes in and of itself an overwhelming cause of anxiety and fear. And having a consistent person that you are dealing with who knows you, who can reassure you, who has dealt with other people that have gone through the same thing, that is a tremendous service that's available. And I feel very fortunate that we have someone that is in that role.
And what else, Dr. Kuras, makes our program, Holy Cross Health's program, so unique as far as lung and thoracic surgery?
So when we think of our program here, we think of a couple of things. We think of a family environment where everything is local. You come to your appointments locally. You get your treatment done locally, whether it is diagnosis, whether it's surgery, whether it's adjuvant treatment, as in chemotherapy or radiation. Everything is encompassed in our program here. We have every specialty available to assist the patient from beginning to continued treatment to surgery to follow-up care. We have the ability to care for not only our patients, but our patients' families, because you're not finding that you have to travel a distance, and we're always right here.
Great. We just had a question come up on Facebook Live. Dr. Steinberg, why is collaboration with other medical specialties so important in treating lung cancer?
You know, I think that having the opportunity to interact with people focused on the same problem but from different perspectives has expanded the effectiveness of each of us as a group, as opposed to working individually. For instance, if we have patients that have slightly more advanced disease, let's say stage 3A disease, okay, if we can treat them beforehand with chemotherapy and even radiation, or there's chest wall involvement and we use radiation and chemotherapy first, and we shrink that tumor, it then makes our opportunity as surgeons better to remove everything. And then afterwards, getting an additional course of chemotherapy or targeted immunotherapy, even more effective and durable. We know that if a person gets operated on first and then gets chemotherapy, the results are not as good in comparison to getting chemotherapy first and then surgery. And the reason is, as surgeons, we are slicing through the tissue. So we are disrupting the blood vessels and the lymphatics to a particular region. So if we then remove something, disrupt all the lymphatics, disrupt all the blood vessels, and then give chemotherapy, the chemotherapy can't get to where it needs to be.
So the timing is very important.
So the timing is correct, is extremely important. And the natural inclination is, I just want this cut out and gotten rid of. But that's a mistake. And it's been through a lot of arduous research. And this has been the contribution of many, many patients to move the ball forward. That we have learned that there is actually, it's important to have the correct sequence transpire. The other thing is some people have advanced lung disease. And so we don't work by ourselves. So we need to get them through these procedures, and we need to work with our pulmonary colleagues to make sure that people are getting just enough surgery, but not more, so that they can continue to breathe without oxygen. And that's one of the things we've developed techniques where we do what are called segmental resections, where we're doing...
And what does that mean exactly?
Right, so we're doing a true cancer operation where we're removing an entire anatomic distribution, including the blood vessels, the lymphatics, and the airway that go to a particular zone of the lung. But we are leaving other uninvolved parts of the lung to preserve lung function. So for patients who have borderline lung function that can't have half of the lung removed, or a third of a lung removed, we still can do a extremely good cancer operation to give them the benefit of surgery, but still preserve.
So one of the first things that we look at when a patient comes to us, let's say with a CT scan and a nodule found, is we first speak with the patient, of course, and ascertain their history in the sense of previous smoker, secondhand smoke, spouse smoked, etc. We get a background history of other medical problems because this patient could have been exposed to tuberculosis at a younger age, and that, I would say, that almost oddly enough reassures us slightly that we might not be dealing with a cancer, we might be dealing with a benign process. So when we move forward and now say, okay, we have a diagnosis or we believe that this is a malignancy, we push forward with a couple of tests. The first test is something called the PET scan. And we describe the PET scan as a radioactive sugar tracer. So this is injected into the bloodstream via an IV, and you undergo something very similar to a CT scan, which is from head to mid-thigh. This PET scan, the sugar tracer itself, goes to areas of tissue that are very active and actively dividing. So for example, when we know the tracer goes to the heart, that's because your heart muscle is constantly pumping, and we expect that to happen. But other areas that show up as positive on a PET scan are either areas of infection or areas of ongoing cancer where those tumor cells are active. So that's one study that we get, and we do this study to just make sure that there aren't any other areas of disease, so we can tailor the patient's care, as Dr. Steinberg just said, very appropriately, whether via chemotherapy, whether via chemotherapy then surgery, or whether we introduce radiation as well. That being said, the next study we obtain is something called pulmonary function tests. And you can see from all these studies how everything is so multimodal. You know, we get a PET scan, this is discussed with medical oncology and radiation oncology. So just by that, you're introducing a multifaceted approach. You get your pulmonary function test to make sure that patients can tolerate surgery, that you are obtaining a good quality of life for them while also obtaining the best treatment course possible. And just by obtaining pulmonary function tests, you've also incorporated pulmonologists and their primary care docs into their system of care.
Excellent, thank you. We just have one more minute before we close. Dr. Steinberg, anything else you can share about what makes our program so unique?
I think we're very fortunate that, as Dr. Karras said, we have all the specialties together in one program. We have extremely powerful diagnostic tools that are state-of-the-art, and that we have 3 robots in our program, and that we're doing, again, state-of-the-art surgical procedures that are helping us not just discover the tumors, but also to eradicate them. And then with our medical oncology colleagues, we now have immunotherapy, we have tyrosine kinase inhibitors, which is another form of targeted chemotherapy. We are very, very fortunate at the moment that we're at. And the advances are coming at such a fast pace that what is true today didn't exist even a year ago. And the future is extremely bright in that regard.
This is very exciting. Thank you both for answering the questions. We are out of time. If we did not get to your question, we're planning to provide additional feedback through Holy Cross Health's blog, or we can also connect with you one-on-one through our lung cancer program channels via phone, email, or our website. They both mentioned our amazing nurse navigator, Denise Holford. Her information is denise.holford@holycrosshealth.org. You can also call our Hope line at 855-424-4673, or visit holycrosshealth.org/lung/cancer. Thank you very much.
Find the care you need at holycrosshealth.org.